Good evening, everyone. I am Dr. Kshitija Patil. I am a consultant clinical geneticist at Apollo Hospitals in Navi, Mumbai. On behalf of Organization of Rare Diseases India, ORDI, I extend a very warm welcome to all of you joining us today for another session of ORDI Rare Info series. ORDI continues to play a pivotal role in raising awareness about rare diseases by bringing together clinicians, researchers, patients, caregivers, and advocates on a common platform. Such discussions are invaluable in promoting awareness, facilitating early diagnosis, and ultimately improving patient care. Before we begin, I would like to inform everyone that today's session is being recorded and will be available later on the ORDI YouTube channel. So today's topic is newborn screening for hemoglobinopathies. Newborn screening is one of the most effective public health interventions, allowing early diagnosis of serious disorders before symptoms develop and enabling timely treatment that can significantly improve the outcomes. India carries a substantial burden of hemoglobinopathies. Around 3 to 4% of Indians are carriers of beta thalassemia, and nearly 10,000 to 15,000 babies of thalassemia major are born every year. India also accounts for almost 1/6 of all babies born globally with sickle cell disease. These numbers highlight why newborn screening is so important. It enables early diagnosis, timely intervention, and better long-term outcomes for the affected children. Important topic, privileged to have us today an expert in this field. It is my pleasure to introduce Dr. Bhavna Dhingra. Dr. Bhavna Dhingra is a professor of pediatrics at AIIMS Bhopal and is trained in hematology and genetic disorders. She serves as the nodal officer for the Center of Excellence for Rare Diseases and the DBT Nidan Kendra for the diagnosis of common genetic disorders. She also heads the weekly genetic clinics at AIIMS Bhopal and is a certified pediatric bioethicist. Her major areas of interest include newborn screening, hemoglobinopathies, bleeding disorders, and rare genetic disorders. She is also the nodal officer for the Regional Center for Excellence for Nutritional Rehabilitation, Resource and Training. We are delighted to have her with us today. Before we begin, I would just like to inform the participants that if you have any questions, you can put them in the Q&A section and we'll address them at the end of the talk. Bhavna ma'am, thank you so much for joining us today. Over to you, ma'am.
Thank you, Dr. Kshitija, and thank you, Mr. Prasanna and the ORDI team for having me here and giving me this opportunity to talk on this very relevant and important topic on newborn screening for hemoglobinopathies. Can I start sharing my slides now?
Yes, ma'am.
Can you see my slides?
Not yet, ma'am.
No?
Not yet, ma'am. Are you seeing the share screen button, ma'am, at the bottom? Yes.
We just checked.
Yes, ma'am. I think it will come up maybe.
Now?
Not yet, ma'am.
Okay, just give me a minute.
Sure, ma'am. Maybe you can try sharing the entire screen, ma'am, and then opening the presentation. Yes, ma'am. Now we are seeing your screen, ma'am. Yes, ma'am.
Now?
Yes, and now the presentation is in screen share, in full screen mode, ma'am.
Yeah, okay. So, good afternoon, everyone, and sorry for this technical glitch for about a minute. We will go ahead with the newborn screening for hemoglobinopathies. So, how the talk will be outlined is that we will talk briefly about the concept of screening and newborn screening, understand the need, why screen for hemoglobinopathies, The techniques available for newborn screening for hemoglobinopathies, the current status of NBS screening in India, challenges in the implementation of universal newborn screening, specifically hemoglobinopathies, and what is the way forward beyond these challenges. So WHO has defined screening as a presumptive identification of unrecognized disease in a healthy asymptomatic population, which means that the population does not show any symptoms of disease, using tests, examination, or other procedures that can be applied rapidly and easily to the entire target population. So this is what screening in general means. Now, why do we need screening? India has 1/5 of the world's annual childbirth. That means 20% of children born globally are born in India, and 50 to 90% of children in India and Africa succumb before fifth birthday. We all know that we have very poor infant and neonatal mortality rates and child and maternal health indicators. So screening programs are the need of the hour to ensure a healthy outcome for every child who is born. Applying the concept or definition of screening to newborn, so what we do is that in the newborn period, when the baby is asymptomatic, early neonatal life, we take a sample, and the sample collected could be either blood, serum, urine, and screen it for specific disorders. If you are able to find something which is positive on a screen, do a confirmatory test, establish a diagnosis, and intervene early so that you can prevent complications and also create awareness for prevention of such disorders in the subsequent pregnancies. Now, newborn screening could be either point of care or sent out. By point of care, we mean at the patient's bedside or where the baby is born. So, critical congenital heart disease screening using pulse oximetry, screening for retinopathy of prematurity, and hearing screening is our point of care screenings. Or it could be sent out, that is, the samples are taken and sent out to the laboratory. This could be in the form of dried blood spots or cord blood, which can be collected and sent out. And the disorders which can be screened for are hemoglobinopathies and a host of metabolic disorders or inborn errors of metabolism. Now, the method of taking sample for newborn screening, I will not go into the details. So, we know that we have a Guthrie or a Whatman filter paper of a specific distinct with predefined circle or areas in which you have to collect the blood drops. Each circle should have only one single blood drop collected. There should be no overlapping of drops, or half-filled or inadequate samples should not be taken. We should take adequate samples, one drop in a circle from the lateral side of the heel of the newborn baby. You can see the well-defined areas, and a non-cutting lancet which does not injure the newborn baby is specifically used. So normal needles should not be used. This is the heel area which should be used for collection of the blood sample. In winter season, or if it is extremely cold, the heel can be pre-warmed, and then using the non-cutting lancet, these areas can be pricked and blood spots can be dabbed onto the filter paper, ensuring that the filter paper does not touch the heel and the drop is allowed to fall freely onto the filter paper. So that is how we collect newborn screening samples. These samples should be allowed to air dry. Once they are dried, they can be transported from peripheral remote areas to the central lab and can be stored appropriately, from which DNA can be extracted even at later dates for analysis. So what time these samples should be collected? That heel prick should be around 48 to 72 hours of birth. The blood spot is then dried and can be tested for several disorders, including metabolic disorders and hemoglobinopathies. This helps to transfer easy collection and transport from even peripheral and remote areas to central areas, so that the screening program can be implemented irrespective of the physical or geographical location where the baby is being born or delivered. Now, which disorders should you screen for? So, as early as 1968, well-defined criteria known by the name of Wilson and Jugner criteria were laid down. So, the disorder that you are going to screen for should be a biochemically well-identified disorder with a known incidence in the population, having significant morbidity and mortality if left untreated. The sample collection and transport should be easy, as we discussed just now. There should be a testing method which is available, simple, safe, specific for the disorder and cost effective. And once you screen and find a screen positive, effective treatment should be available for that disorder, in which early intervention is known to improve outcome. If for a disorder you do not have treatment available, there is no point in screening and then stigmatizing the individual for life without providing a definitive treatment. So you must know which disorders that you can screen for. Based on these criteria, ICMR for India had suggested a core panel which consists of screening all babies. Universal screening means all babies who have been delivered should be screened, and targeted screening means individuals or babies who have a family history or are high risk should be screened for a given disorder. So the core panel for universal screening includes congenital hypothyroidism, congenital adrenal hyperplasia, G6PD deficiency, and sickle cell disease, wherein universal screening is mandated. The expanded panel targeted screening according to the geographical location or the street must include thalassemias, inborn errors of metabolism, and cystic fibrosis. Now, why hemoglobinopathies fit into the core panel? If we apply the Wilson and Jugner criteria to hemoglobinopathies, we know, especially in this part of the country, that this is an important health problem. There is an accepted treatment available. Diagnosis can be established easily. Established treatment is available. There is an early symptomatic stage. If intervened at this stage, complications can be prevented or delayed. And there is a suitable diagnostic test available to screen and to diagnose. To understand the burden of hemoglobinopathies, look at the geographical distribution. Almost the entire world is affected by hemoglobinopathies, with some countries and continents like the Asian continent, India, and the African continent affected to a greater extent. But the distribution is worldwide and is not limited to a specific geographical location. Coming to the prevalence in India, if we talk of thalassemia, the largest number of children with thalassemia major are in India, around 1.5 lakh, and the number is increasing steadily. Added to that, there are around 3.6 to 3.9 crore carriers of beta thalassemia. 10,000 to 15,000 babies with beta thalassemia major are born each year. So an average prevalence rate of around 3 to 4% in the general population, while a higher frequency is observed in certain communities like Sindhis, Punjabis, Gujaratis, Mahars, Kolis, Saraswats, etc. If you look at sickle cell disease, the most common hemoglobinopathy, the prevalence is variable with frequency of carriers reported as high as 20 to 30% in many tribal communities, up to 35% in certain regions of central and western states. But it is a myth that sickle cell disease is seen only in tribal communities. It is not restricted only to the tribal communities due to intermingling and migration and immigration of populations in today's world. Hemoglobinopathies are no longer restricted to a given geographical region. There are more than 25 million carriers of the gene hemoglobin AS and 1,25,000 patients of sickle cell disease in our country. That's a huge economic burden. Again, if you see the distribution of alpha thalassemias spread across the globe, with some continents like Africa and Asian subcontinent affected more severely, and the beta thalassemias also are spread across the globe, transfusion dependent and non-transfusion dependent both across the globe, not restricted to any geographical location. There are pockets of high density in certain areas, but they are not restricted to any given country or continent. Now, newborn screening's efficacy has been already established globally. The strong effect of such a screening program in reducing mortality due to hemoglobinopathies has been well demonstrated in the US, where as early as 1975 to early 80s, around 85,000 newborns were screened, irrespective of their ethnicity or background, and the prevalence was found to be 1 in approximately 950 births of sickle cell and 1 in 4,200 births of approximately thalassemia syndromes. So, the overall mortality rate when sickle cell was diagnosed in newborn period was less than 2%, while it was 8% when diagnosed beyond 3 months of age. So, there was a more than fourfold rise in the mortality if sickle cell disease was diagnosed beyond the newborn period. So, with implementation of universal newborn screening for sickle cell, and early intervention in the form of initiating penicillin prophylaxis, mortality was reduced by more than half in affected children aged 1 to 4 years. So we can definitely see the impact of a universal newborn screening program for hemoglobinopathies. Not only mortality, life expectancy also increased from a median of around 14 years to the 4th to 5th decade of life in males and around 60 years in the females, which is a significant increase in the life expectancy. Coming back again to our own country, there is a significant burden in the country. If we have a total of 6 million individuals affected with sickle cell disease, approximately 25% or 1.5 million reside in our country. And as you can see that the areas marked in red reflect the pockets of high density of sickle cell, but it is spread across the country. These are some of the states. This is data courtesy Ministry of Health and Family Welfare. Some of the states which have very high burden: North, Himachal Pradesh, Rajasthan, Gujarat, Central Belt of Madhya Pradesh, Vidarbha, Chhattisgarh, Maharashtra, Odisha, Jharkhand, going south to Andhra, Karnataka, even Kerala and Tamil Nadu are states with very high prevalence of sickle cell disease. If you see that a total of 37,000 individuals who were screened across the countries in the tribal population, out of 37,000 individuals screened, sickle cell disease, although was found in around 1%, but the carrier frequency was as high as 15%. It was high in certain areas, like 40% if you see in Navi, Tamil Nadu, and 23% in Seva, Gujarat, but an overall carrier frequency of around 15% in tribal population across the country. Given the high prevalence of practices like endogamy and consanguinity, this prevalence is extremely high in certain pockets. Now let us see what are the different beta globin haplotypes or the sickle cell haplotypes across the globe. The African haplotype or the Senegal, which is commonly the Senegal or Benin or Bentu in east of Africa, while in India and Asia we have more of the Asian haplotype. What is the importance of understanding the haplotype is that in the eastern province of Southeast Asia or Saudi Arabia and India, it is mostly the Arab Indian or Asian haplotype which is associated with a higher fetal hemoglobin level. So we know that higher the hemoglobin F level in an individual with sickle cell disease, the lesser is the severity. But things do not go in a linear way or are not related in a very simple manner that higher the HbF level, the disease will be less severe. How? We will see. So it is expected that there is a milder clinical presentation of Arab Indian or Asian haplotype as compared to the Benin haplotype, which is seen in the West and North Africa, and the Bantu haplotype seen in East and Central Africa. 90% of sickle genes across have Asian haplotype, whereas less than 10 few atypical haplotypes, including Bantu A2, and the Senegal haplotype is around 10% of the sickle genes. Now, genotype patterns which are commonly seen in our Indian sickle cell population are predominance of Arab Indian HBS. Along with that, there is high prevalence of co-inheritance of alpha thalassemia, co-inheritance of beta thalassemia, sickle beta thalassemias. As I mentioned, high consanguinity and endogamy, and population clustering and variability, which is seen in different regions of the country. If we compare the HbF levels between the Jamaican and Central Indian cohorts of persons with sickle cell disease, if you look at the Nagpur cohort, the HbF level at age of 1 year was around 25%, while in Jamaica it was 15%. And across the years in childhood, the Indian cohort had higher hemoglobin F level as compared to the African cohort. However, despite higher hemoglobin F level, 12 to 30% in India, whereas others have an average of 3 to 7%, it has been shown that clinical events are significant and the disease is more severe in our country as expected with a higher hemoglobin F level. Now, there are determinants beyond the genotype like environmental, nutrition, multiple infections, lack of healthcare access, infections, etc., which contribute to this disease severity. In the country, if we look at the disease journey of sickle cell disease till now, the earliest identification of sickle cell gene was in 1950s, And it took 50 years for the concept of newborn screening to be introduced around the year 2000. So that means only around 25 years ago, we have started talking about newborn screening in sickle cell disease. While as we discussed in developed countries like America, they had a well-established screening program in 1975 and early 1980s. Now, the government has recently launched the National Sickle Cell Anemia Elimination Mission, which the target is to eliminate sickle cell by 2047. And as you can see, apart from other components, there is a large focus being given on newborn screening. Without identifying newborns by screening in the early neonatal period, it is not possible to achieve this target of sickle cell elimination by 2047. Hence, newborn screening remains an integral part of this elimination mission. Coming now to the principle of newborn screening, we all know that around 6 months of age or at birth, around the levels of gamma chains are high and a hemoglobin switch takes place around this time after 40 weeks of gestation, that is soon after birth. And at birth, the fetal hemoglobin F, the alpha 2 gamma 2 is the predominant hemoglobin, while it slowly declines and the adult hemoglobin takes place. So the composition rather than alpha 2 gamma 2 becomes alpha 2 beta 2. So HbF progressively decreases while adult hemoglobin slowly increases. And by 1 year of age, the HbF level is less than 1% usually. So while most of the HPLC reports that we have in adults are based on detection of A and A2 levels, the newborn screening equipment wherein HPLC utilizes is based on detection of the HbF level. That's the basic difference because that is high in the early neonatal. Now, hence further, when we talk of newborn screening for hemoglobinopathies, I shall be predominantly focusing on sickle cell disease in the early neonatal period. So we know that sickle cell disease encompasses hemoglobin SS or the homozygous state of sickle cell anemia, which is the symptomatic state and associated with a host of complications. Whereas other combinations with HBS and other mutations such as HBC, HBD and sickle cell with HBO Arab lead to sickle cell disease or compound heterozygous states. You can also have sickle beta thalassemia and SDSE combinations wherein combination of like disorders like D, Punjab are otherwise asymptomatic, but when they are compound heterozygous with S, like one is sickle and the second allele is hemoglobin D, the phenotype becomes much more severe. So when we say sickle cell disease, it encompasses all these syndromes, homozygous SS and the compound heterozygous states as well. Now, the various technologies which are available could be either hemoglobin electrophoresis, which we know was an early method wherein the mobility of different hemoglobins across the gel was analyzed and based on the different mobility under a power source moving from anode to cathode, different hemoglobins could be separated on the gel. Then came isoelectric focusing. So isoelectric focusing utilizes the principle that at low pH, most proteins will have a positive charge, while at a high pH, most proteins will have a negative charge. And in the presence of an electrical field, the cathode and anodes will pull the proteins to their isoelectric point, where each individual protein will possess a neutral charge. So different hemoglobins will get separated this way, giving us the hemoglobin composition of a given sample. So isoelectric focusing and hemoglobin electrophoresis have been in use earlier for performing newborn screening for hemoglobin electrophoresis. Of late, most of the tests are being performed at the capillary electrophoresis or the capillary neonat instrument, which specifically utilizes, as I mentioned, the presence of HbF, based on which it analyzes the various samples. And this is how you get different peaks or the hemoglobin separated in different zones. So you can see the peak of hemoglobin a high level of hemoglobin F, and there is another peak in the S zone. So FAS, which this indicates that there is presence of sickle hemoglobin also. So when we apply this concept to screening, which means that around 90 to 96 samples are run in a single plate, on the screen you can identify the abnormal ones and you can analyze these chromatograms in detail. so that at one glance you are able to identify which samples are giving you the abnormal results. So just taking you through some of the sample results. Here you can see that there is F and A. So this is FA is normal pattern. Now again pertinent to mention that as the age of the newborn increases, the F level starts going down and the adult hemoglobin starts appearing. So if the sample has been collected beyond 7 days of life, you will also see hemoglobin A2, the F level going down. So it's very important to mention the age of the neonate at which the sample has been collected for newborn screening so that the results can be interpreted appropriately. If you see this again, F is a large peak, some amount of A, and a small peak of hemoglobin S, which is around 4.3%. So this is probably a heterozygote for FAS or sickle cell heterozygous. Here, if you see that hemoglobin A is totally absent, there is a large peak of HbF and the HbS peak of around 9% here. Now, again, pertinent to mention that these are only screening results and need to be confirmed before giving a confirmed diagnosis. When we say screen positive, we always re-punch a given sample, and if the screening is positive on the second punch also, we label it as screen positive, whereas a confirmed diagnosis is given only if after screening results, another method has been used and a confirmatory test or a molecular test has been performed to label the individual as a given, for any given condition, labeling the patient with that given diagnosis. So do not label the patients as for suffering from any disorder based only on the screening results. A confirmatory diagnostic molecular test is mandatory to give a diagnosis because you are going to label the individual for life. So if you have HB, if you can see some amount of hemoglobin coming here, which is HB bar, or here you have hemoglobin A, and this is a large peak of HbF. So if you have FA and bar hemoglobin, then around with, if there was an S also, I would suspect a sickle and an alpha thal here. But since there is no S, this is probably only a suspected alpha thal carrier. So this program also helps in detecting alpha thal carriers, although with some specialized ratios also which are taken into account. If you look at this sample, you can only see hemoglobin F. There is no A and no other P. So only hemoglobin F, high hemoglobin F, which means with absence of hemoglobin A that we are probably dealing with beta 0 thalassemia here. So these are again some of the depictive results showing peaks in the S region. FAS type, this is probably depending upon the quantification of HbS, whether hemoglobin heterozygous for sickle cell or homozygous for sickle cell. So coming to Indian experience using HPLC and performing newborn screening. So we know that HPLC has been used in various studies across the country, and the beta thal short program. There have been two programs which have been used. The beta thal short kit has been used as a better in diagnosing the presence of hemoglobinopathies in newborns in our population. So using these HPLC based programs for resource poor countries, a suggestion was made that states with high prevalence should go for universal screening for all individuals less than 40 years, including newborns, which is mass screening, and states with low prevalence should undergo screening in the tribal pockets or blocks or villages of high endemicity, which we earlier discussed as target group screening. So both mass screening and target group screening can be performed using the HPLC based programs. The technologies, as I mentioned, which have been used in India, the variant NBS machine or the from Biorad Laboratories USA from DBS, or the variant hemoglobin testing system from Biorad for cord blood samples using either the sickle cell short or the beta thal short program, as I mentioned. The beta thal short program has the advantage of picking up other hemoglobin abnormalities like hemoglobin fountain blue, O Indonesia, and Coyadora, which are rare non-deletional alpha chain variants also. Now, after, as we discussed, hemoglobin electrophoresis, isoelectric focusing, and hemoglobin HPLC as the traditional methods of detecting these hemoglobinopathies, Since we are talking of screening, and screening needs to be applied to the remote communities as well, a need was felt for point of care testing for rapid diagnosis of sickle cell and other hemoglobinopathies. Diagnosis to be established within minutes using a low cost portable device which did not require electricity, which did not require trained manpower, and was easy to perform to give results within minutes. There have been various point of care devices which have now been made available, and we'll see the details in a short while. The first of these was around hemotype SC, and the hemotype SC has been studied in various clinical trials, wherein as comparing to the gold standard HPLC technology, the accuracy is close to 99 to 100% in diagnosis of sickle cell disease, establishing the fact that point of care testings can be used in remote peripheral areas also for giving or establishing a diagnosis of hemoglobinopathies within minutes. This again shows the results of trial of hemotype SC versus newborn screening HPLC in newborns as well as adults, giving a very high concordance rate. Those who were diagnosed positive with ASSS in the hemotype SC were also established positives with the HPLC systems, concluding to have a high sensitivity and specificity. Again, the details of various phenotypes detected by hemotype SC and HPLC showing a very high sensitivity and specificity for detection of hemoglobinopathies using the point of care hemotype SC device. Now, this is a list available from the ICMR website, wherein you can see that close to 17 kits or 17 point of care testing devices are available based on different technologies which have been validated across the country at different size. And you can see the sample size also, that close to around 10,000 samples have been tested using various devices, establishing a very high sensitivity and specificity close to 98 to 100% using all of these point of care screening devices. So point of care screening devices are readily available. However, they are unable to diagnose sickle beta thalassemia, the compound heterozygous states, and the high level of HbF may interfere with the results of many diagnostic tests. They are available. They are not validated for cord blood samples, but they are validated for the fresh sample or the DBS sample which is taken. Prior validation studies should be available before using these technologies, especially for newborn screening. So as I shared a list of validated devices available on the ICMR website, only these validated point of care tests should be used when you are using for newborn screening. The current status of newborn screening hemoglobinopathy status in India, if you see that from 2019 to 2024, around 63,000 newborns were screened across these 5 or 6 states in endemic regions, and 11.4% was the sickle cell carrier frequency, and approximately 1% in newborns were identified as sickle cell disease. So, universal newborn screening is currently being implemented only in parts. India, as of now, still does not have a universal newborn screening program in place. Only in parts of South Gujarat, Maharashtra, Madhya Pradesh, Chhattisgarh, Odisha, and Tripura, newborn screening programs universally for hemoglobinopathies are being taken in small niche and pockets. Newborn screening program as a state program has been implemented only in a handful of states: Goa, Kerala. Recently, Delhi has joined with the launch of Anmol program, and Chandigarh. They have state-run programs for newborn screening. So there is a long way to go to implement universal newborn screening across the country. Let us see 2 cohorts wherein newborn screening and follow-up program has been well established, like the South Gujarat tribal population from Dr. Yazdi Italia's group. They studied newborn screening was performed in a select few of these public healthcare facilities, wherein they screened every newborn who was being born, and these newborns were mainly coming from tribal populations, and approximately close to 5,000 newborns were screened. Homozygous identified across all tribal populations were approximately 2%. Sickle beta thalassemia was also around 0.5%. But if you see the frequency of HbS rate, it ranges up to as high as 23 to 25% across the tribal populations. Now, not only have they screened, they have also followed up these cohorts. One of the cohort in Mumbai, even during COVID-19, they were able to follow these children and provide counseling, even through tele-counseling services, so that newborn screening services were continued even during the pandemic, so that children were not missed, and follow-up family screening was done with the family for confirmation of diagnosis. If they were identified as sickle cell disease, again family counseling was provided and early interventions in the term of early initiation of hydroxyurea and penicillin prophylaxis and early screening for complications was instituted. These two cohorts in Valsad in South Gujarat and Nagpur in Maharashtra, Dr. Deepti Jain's group, around more than 5,500 babies screened, 687 identified as sickle cell trait, and 46 were identified as sickle cell disease, out of which 33 were homozygous for sickle cell and 13 were compound heterozygous for sickle beta thalassemia. In a follow-up, what was found that the majority who became symptomatic presented after 2 years of age in the Gujarat cohort. 7 babies had severe complications who were either sickle cell homozygous or compound heterozygous with beta thal, and the severe complications were either severe infections, vaso-occlusive crisis, severe anemia, or acute chest syndrome. There was one mortality at 4 years of age, and when the genetic modifiers XMN polymorphism, although could not be studied across all babies, but in 24 SS babies, XMN1++ polymorphism was found in all of them. So, not only the sickle cell, as we mentioned earlier, that not only because there is high HbF, the disease severity is not mild. There are other modifiers of the genotype-phenotype correlation, like co-inheritance of various polymorphisms, alpha thalassemia, and compound heterozygous states. The HbF levels varied from 12 to 30% among sickle cell homozygous baby between 2.4 to 5 years of age at follow-up. And the prevalence of alpha thalassemia was very high, approximately 92% in this follow-up population. And this was the most common deletional phenotype of alpha thalassemia associated. In the Nagpur cohort, as compared to the Gujarat cohort, which presented more than 2 years of age, several babies in the Nagpur cohort presented much earlier, and 45% of these children required hospitalization between 3 months to 2 years with infections, severe anemia, and vaso-occlusive crisis. 8 had sepsis and 6 babies died. Haplotyping of these babies revealed again 94% had Asian haplotype, while 6 were related to the Bantu A2 haplotype and 3 to an atypical haplotype. Again, the mean HbF level was significantly high, more than 20%. So you see that even with a higher mean HbF, there were significant infections and painful episodes which were present in this population. And again, 28% co-inheritance of alpha thalassemia was found in this cohort. This is just the graphical demonstration of the various episodes that were seen in the Nagpur cohort, like they required seizures, they required blood transfusion, around 3 had sepsis, there was acute febrile illness, and 42 required admissions. There were 2 babies who had significant dactylitis, which was present. Significant point again here that as compared to the African haplotype, dactylitis is seen less commonly in the Asian haplotype. Now, recently, a systematic review and meta-analysis has been published from our country on the birth prevalence of sickle cell disease in India, which summarizes all the newborn screening programs which have been initiated in India and have been following the mean follow-up of some of the, as I mentioned, the Gujarat and the Nagpur cohorts has been more than 5 years, whereas there are some other cohorts also which have performed a significant number of newborns have been screened, and the prevalence of carriers again as high in the range between 5% to 20% has been reported. So some of these are still in early follow-up, and the follow-up of these cohorts has not been reported. Now, across all these newborn screening program implementations in the country, some factors which have been identified as facilitators or the barriers towards these implementation. There is a huge stigma of local beliefs and customary practices. Community practices restrict blood collections. There are impediments in blood collections and testing due to early discharges from the hospitals, administrative delays, coordination with other healthcare schemes and other stakeholders, data and record management, challenges with human resources, which all of us in the healthcare system face at the organization level, at individual level, and even at provider level. Now, what are some of been the facilitators of implementation of this program is effective coordination, better access to resources and technology, integration with the existing health system and other stakeholders, and repeated trainings on sickle care disease care and management, and augmenting community awareness through various awareness programs which are being held from time to time. A word about role of machine learning and artificial intelligence in implementation of newborn screening. Various machine learning techniques are available and choosing the most effective approach again remains a big challenge. Machine learning holds a potential by reducing false positivity, by increasing the specificity, improving the positive predictive values, and uncovering previously unrecognized trends in data. So to summarize, what are the challenges in implementation of universal NBS across the country? As we mentioned, lack of awareness. There is a high population load, and because of this, there is a rapid turnover on the beds and early hospital discharges. So newborns are discharged home even before the DBS samples can be collected. There is differences in illness frequency across various ethnic groups and communities. The cost effectiveness of implementing a nationwide program. We still have conflicting health priorities, still have high mortality due to infectious causes like pneumonias and diarrheas and other priorities which take over. Poor access to healthcare and counseling services, ensuring quality control in sample collection, storage, transport, performing of tests, relaying of reports, post-test counseling, all needs to be taken care of, and greater or better intersectoral coordination with all stakeholders is still the need. Now, how can we address these challenges? As I already mentioned, that a mission program has been launched to eliminate in July 2023, to scale up newborn and antenatal screening. So without having a geared up newborn screening and antenatal screening program, it is practically impossible to think of eliminating sickle cell. So we need to link the screen babies to NHM supported care coordinators. There has to be a ownership of the program along with built-in follow-up systems, integrating the diagnosis of sickle cell into the health and wellness centers and the digital health IDs so that these patients can be followed up and tracked and provided lifelong comprehensive multidisciplinary care. Some of the lessons for newborn screening of hemoglobinopathies that we can learn from the Indian experience, that although NBS has been implemented only in selected pockets, the feasibility and utility of DBS for newborn screening is established well beyond doubt. The potential strengths of the system are that there is HPLC machine which is available in most of the district hospitals along with consumables and manpower for interpretation. There is availability of clinics providing comprehensive care in few selected endemic regions, which can be created as a model, and that model can be replicated across the country to create a comprehensive model not only for screening but also for follow-up of the screen positive individuals. There is now greater availability of genetic studies across the country with strengthening of centers of excellence across the country for diagnosis of hemoglobinopathies. There is fair proportion of follow-up. Patients can be followed up now with advances of AI and machine learning, as we saw in the Gujarat and the Valsad and Nagpur cohorts, that approximately 70% could be followed up for confirmation of diagnosis and long-term follow-up. Ongoing education of family members helps a lot. Use of genetic diagnosis for counseling and antenatal diagnosis, and again, use of mobile phones for follow-up and education. What we need is strong policy advocacy from patient groups, ensuring funding for establishment and sustenance of these programs, and establishment of comprehensive care centers and multidisciplinary care for these individuals, establishing national and international collaborations and implementing point of care testing in peripheral remote regions. Begin with endemic districts with tribal populations with high prevalence of sickle cell, and then expand in a phased manner to less endemic districts and less affected states, leading to a countrywide implementation of the model so as to achieve the target of eliminating sickle cell by 2047. Sharing our own experience from Center of Excellence for Rare Diseases at AIIMS Bhopal, with support of NHM MP, we've been able to establish the newborn screening for hemoglobinopathy laboratory in 2021. And this is probably the only healthcare facility in the government sector healthcare facility where we are performing newborn screening for hemoglobinopathy across MP. And we have trained across 29 tribal districts for collection of DBS samples, both in online and offline mode, so that there is no difficulty or challenge in collecting the DBS sample and transporting it to the laboratory. We had started initially with collecting samples for 2 districts, but with ongoing support and discussions with the National Health Mission in the state, we plan to implement this across all districts in a phased manner. What challenges we faced was to retain skilled manpower, coordination of all activities, provision of good samples from peripheral healthcare facilities, ensuring follow-up of screen positives, and then limited availability of confirmatory diagnostic tests. The sustainability of running this program, we have budget constraints. There are still other health priorities. Even healthcare workers do not understand the importance of implementing a newborn screening programs, and delays in the procurement of various reagents to ensure that the program is continued without interruptions. Repunch of screen positives, ensuring telephonic follow-up and review at AIIMS Bhopal. Lack of funds for confirmatory test of screen positives and poor follow-up rates are again some challenges. So as I mentioned that we have ongoing efforts to increase awareness and sensitization about newborn screening across all cadres, not only healthcare workers, but also for general public. So we keep conducting awareness sessions, organizing quiz competitions, PG seminars, various activities like Rangoli and slogan competition or skit by the nursing students so that more and more people in the community become aware. In our future plans, we plan to, under the DBT Nidan Kendra and Aspirational District Program, we will soon be implementing newborn screening in the district of Vidisha to screen around 10,000 newborns and 5,000 antenatal females annually. And ongoing discussion, as I mentioned, with NHM MP to scale up the program across the 29 districts, taking 2 to 3 districts with high burden in the current financial year. So I will stop here with the carry home message that early diagnosis by screening can prevent serious consequences. Newborn screening for disorders like hemoglobinopathies and congenital hypothyroidism is the NPR. Also to emphasize that screening does not give a confirmatory diagnosis and establishing a confirmed diagnosis and follow-up is required. Thank you so much.
So, thank you so much, ma'am, for that excellent and insightful talk. I think it was very detailed, like for a newborn screening for just hemoglobinopathies. And I came to know so many new things, including like availability of so many point of care devices, the machine learning aspect, and a detailed review of all the newborn screening programs happening across India and even from your center, ma'am. And especially like all the effort being taken for increasing the awareness. So we will now move on to the question and answer section. We have a few questions in the Q&A section. I will read them for you, ma'am. Mr. Vikas Bhatia is asking, which disease can be included in a core panel for newborn screening? And can it vary by region like north, east, west, south?
Yes, sir. So, Vikas Bhatia ji, first of all, thanks for attending the session. And I really appreciate your dedication and commitment towards the cause. So, as far as ICMR recommendation, as of now, the core panel does not vary by region. The expanded panel probably can vary by region, like in certain communities, like in the state of Jammu and Kashmir, we have a high prevalence of disorders like cystic fibrosis. So that can vary from region to region, but the core panel across India as of now, as per ICMR guidelines, is the same across the country, which includes CH, CAH, sickle cell disease, G6PD deficiency, and biotinidase deficiency. Right. Can we apply Kerala model in every state? We would love to. provided every state takes up that challenge and funding support is available. We would love to apply the Kerala model. I would like to see it implemented across the country.
True, ma'am.
There is a question, is there a typographical error? 50 to 75% of newborns in India die before 5 years. No, I don't think it is 50 to 75% of, there must be a typographical errors. It is, I think, 5 to 7% of newborns in India and Africa do not see their fifth birth. I'm sorry for that typographical error if there was.
Right.
After newborn screening, what is the time after which we have to do the confirmatory diagnosis? So, good question. So, if we have a sickle cell peak on the newborn screening, as I mentioned, on the first punch itself, we do not label it as screen positive. From the DBS card, we do a second punch. If that also comes positive, then we label it as screen positive. And as soon as we get that report, we call the family back. If the initial screen was done using capillary electrophoresis or HPLC, it is mandated to confirm it using another method or technology like isoelectric focusing. Or you could go ahead with the family screening. You can screen the parents for the carrier, both the parents for the carrier status, and molecular confirmation can be done. If you like to do an HPLC in the newborn period, if this was done in newborn period, and HPLC should be repeated after 6 months of age. Now, this is an ideal scenario, but most of the time, the funding for establishing molecular diagnosis or other tests might not be available. So, carrier screening of the parents using hemoglobin HPLC, which is easily available at most of the even district hospitals, must be done.
Right. Thank you, ma'am. And ma'am, do you think so nowadays even during antenatal period we are trying to screen the to-be mothers for the thalassemia carrier
All
status?
antenatal mothers must be screened for
So
hemoglobin.
that is, yes, ma'am. Right, ma'am. And ma'am, any so we have now this rare disease registry project where we are also trying to have like more information regarding like the exact prevalence and other things. So maybe through these newborn screening also a lot of data must be being like generated, like even from your
Yes,
center on this.
newborn screening will give us the epidemiological data which is not there regarding the exact prevalence. So I would just like to clarify one thing here, that sickle cell disease and thalassemias are not covered under the National Policy for Rare Diseases. However, the ICMR Rare Disease Registry is collating data on prevalence of sickle cell, thalassemia and other hemoglobin.
Right, ma'am. There's another question, ma'am. What is the role of gynecologist for informing parents for newborn screening?
It is like the role of father in bringing up a child. So you cannot separate the mother and the newborn has to be treated like a diet. And because the point of first contact for the mother is the gynecologist. So the gynecologist, all their scientific associations must be actively involved in advocating newborn screening. And the mothers or the expectant couples in the reproductive age group must be informed at their first antenatal visit and given the option of newborn screening.
Right, ma'am. Thank you so much for your insights, ma'am.
ORDI for giving me this opportunity.
Ma'am, if we can take one more question.
Yeah, there is one more question. Are there any specific precautions or specification for sending the sample for newborn if mother is diagnosed with hemoglobinopathy? So if the mother is diagnosed with hemoglobinopathy, ideally what we should do is screen the spouse also. Because if mother, I don't know whether you mean a hemoglobinopathy carrier here for the mother or affected here. So anyways, even if the mother is a carrier or is affected with hemoglobinopathy, the spouse must be tested. And rather than having the option of newborn screening in such a case, I would recommend prenatal diagnosis so that an affected child with hemoglobinopathy is not born. If you're talking about the precautions for collecting of newborn sample on a DBS card, there is no specific precaution except for the general precautions that the blood drop should be collected only single drop on a single circle. It should be absorbed from one end to the other end of the filter paper so that adequate DNA can be isolated. It should be air dried before storing, and one card should not be stored on top of the others so that DNA contamination does not take place. This should be packed in an airtight envelope, a plastic envelope, and then can be transported safely to the lab.
Right.
If parents are carrier for beta thalassemia in ongoing pregnancy, can HPLC use for testing for newborns? So for prenatal diagnosis, we look at the underlying mutation or the confirmatory molecular diagnosis. So if parents are carriers for beta thalassemia, then you must know the underlying mutation, because HPLC will give you false results as it does not, the fetal hemoglobin will be very high in the fetus, and there are other hemoglobin variants also which are there in the fetus which will not be detected and will not give a confirmed diagnosis. So a molecular prenatal diagnosis is always done for the underlying mutation. You must know the mutation in the parents, carriers, and screen for the same mutation in the fetus.
Right. So I think there are no more questions, ma'am. Thank you once again, ma'am, for sharing your expertise and valuable insights. Yes, ma'am. Okay, I thought you were saying. Thank you, ma'am, for sharing your expertise and valuable insights with us today. Today's session has highlighted the tremendous impact that newborn screening can have in improving the lives of children with hemoglobinopathies. I would also like to thank ORDI for providing this wonderful platform for education and awareness in the field of rare diseases. Finally, I thank all the participants for joining us this evening and for your enthusiastic participation. We look forward to seeing you again in another session of the ORDI Rare Info series. Thank you and have a wonderful evening.
Thank you so much, ORDI, and thank you, Dr. Kshitija.